The preferred route for delivering bronchodilator drugs will be via aerosol devices. Through this session, students will learn how to advise patients on the benefits of aerosol therapy and demonstrate proper techniques to optimize its use. Aerosol devices are dispersal systems that break the drug into fine liquid or solid particles that can be carried all the way into the smaller alveoli. Optimally, sizes of 0 to 5 micrometers can reach the smaller airways. This will allow local effects to be potent while minimizing systemic adverse effects. Patients should be motivated to avail of inhalation therapy whenever available because of its ability to deliver targeted doses of drugs with a rapid onset of action in smaller doses and avoiding less systemic and GI adverse effects. When using aerosol devices, it can be predictable that only 10 to 15% of the drug will actually reach the alveoli. Much of the drug may be lost in the airways as a result of several factors. Inertial impaction can lead to the delivery of the drug in a, into the airways, which may encounter the angulated respiratory tree, causing it to deposit in the surfaces. Heavier particles may also be subject to a second force of the force of gravity that causes sedimentation or falling out of larger aerosol particles. A third factor can be the presence of electrical uh, charges within the drug itself, which may interact with the cell surfaces. If the drug does reach into the alveoli, and these are usually the drugs that are less than 5 micrometers, they can encounter Brownian movement or the collision of gas molecules that can interfere with the usual diffusion of drug into the lung. Proper technique can minimize unnecessary deposition of the drug in the airway rather than in the alveoli. It is important, however, that even if the amount that is reaching the alveoli is small, it is actually the desired amount to achieve a therapeutic benefit. Despite variations in the amount of oropharyngeal deposit or loss to the devices, most of these devices are comparable in their efficiency to deliver a therapeutic amount into the alveoli. The three major groups of devices include the meter dose inhalers, dry powder inhalers, and nebulizers. In meter dose inhalers, a pressurized chamber can calibrate a fixed amount of drug that is aerosolized into a spray mist. The drug may be dissolved in a propellant or liquid, usually hydrofluoroalkanes. Many of the newer meter dose inhalers can have a counter to gauge the number of doses that have already been delivered. The advantage of the meter dose inhaler is that it is a portable device which delivers a predictable amount with minimal contamination. It's easy to use although it requires a breathing technique to time the delivery of the dose to the inward breath. We'll see a video on how to use the device. It will require coordination of the inward breath with the actuation of the delivery. High pharyngeal deposition can be expected from the meter dose inhalers because of the pressurized force of the emitted aerosol. The newer counters addresses the problems of uh, difficulty in gauging the number of doses that have been delivered. Among the various devices, the MDI has the largest risk of impaction in the oropharyngeal area due to the pressurized delivery. There is a high velocity and this encounters the sharp airway turns and the smaller airway radius in the branching bronchioles. So 45 to 95% of the dose may impact in the airways. It will be important to minimize this effect by coaching deep breathing, slow deep breathing, and hand breath coordination to limit this uh, type of impaction. Other mistakes that can limit the efficacy of an MDI will be the simple neglect in not shaking the canister, not uh, exhaling, taking an exhalation before the initial breath, giving two dosers by pressing the inhaler repeatedly, not waiting 60 seconds between puffs, or not holding in the breath after the deep inspiration. Some of the aerosol might be escaped by not cupping the mouthpiece, by breathing in after the actuation instead of simultaneous with the actuation. Uneven and shallow inspiratory efforts can limit the aerosol delivery as well. Breathing in too fast or breathing in before activating the MDI. These are common mistakes that should be corrected by observing directly the technique of each patient. S- Spacer devices have in common the presence of a valved holding chamber which will trap aerosol particles. This will be important in slowing down the droplets to decrease oropharyngeal deposition, and it will reduce drug loss because patients are able to time their own breath while the holding chamber traps the aerosol. This will be very helpful in patients with poor hand breath coordination, and its efficacy will be comparable to a nebulized dose. Dry powder inhalers will limit the need for hand breath coordination. These are usually lower costing options than the MDIs. The dry powder devices are comparable to MDIs in their efficacy, but the strength for propelling the particles will not be from a pressurized chamber. Rather, it is the patient's quick and swift breath that will propel the aerosol into the lungs. Like your MDI, 50 to 70% of the dose will remain in the oropharynx. There are several variations of these powder devices. Some have chambers where uh, as the dry powder will be inserted as a capsule, or there are self-loading chambers such as your turbohaler. Common errors associated with dry powder inhalers will be the poor inspiratory effort, not keeping the device upright while loading the dose, not exhaling as much air as possible, and not holding the breath for a period after the inspiratory effort. More recently, the problem of hand breath coordination with MDIs and the inability to inhale forcibly with dry powder inhalers is addressed with breath activated devices. Here, no coordination or high flow rate is required because the trigger of an inspiratory breath will generate a less forceful aerosol plume, which will facilitate drug delivery and deposition in the lung. No propellants are required with the newer breath actuated devices. Nebulizers are reserved for the critically ill patients who have difficulty with inspiratory effort or who have erratic breathing patterns. Patients also who cannot carry out simple instructions may benefit from nebulizers. Using a mechanical compressor, a nebulizer can turn liquid into fine mists that a person can readily inhale through a face mask or mouthpiece. As mentioned, the advantage of a nebulizer will be in delivering a dose without requiring any special effort from the patient, so that it can be ideal for patients who are very young, very old, or who may have difficulty in uh, following any breathing instructions. The disadvantage would be that it relies on a power source and takes some preparations compared with the simple meter dose or dry powder inhalers. It is less portable in this way, although there are small models that are handheld. Generally, this can deliver a spray so that the aerosol mist can be more readily dispersed. It can affect the eyes, for example, or the there are losses from environment spillage of the aerosol. But generally, this is one of the reliable ways to deliver medications for critically ill patients. Thank you for listening, and I hope you'll be ready to share this information with patients.